And let's move on to the last but not least, Team Yusuf from King's College, and he will provide the great experience of King's College on assessment of abdominal bleeding in trauma patients. Please, Tim.
Thank you. Thank you for your kind introduction. Thank you for the wonderful lecture so far. I hope my screen is projecting to you. So we're going to talk today about the assessment of abdominal bleeding in the trauma patient. And as Vito mentioned, we are a trauma centre here at King's, and we've got quite a lot of experience, particularly in the use of contrast-enhanced ultrasound. But really, that's not where trauma started from, where ultrasound started in trauma. Fast scanning, focused assessment sonography in trauma is widespread and has rapidly come to a forefront because ultrasound is sensitive at picking up fluid, and that's the major principle behind it. So it's therefore useful as a screening tool based on the principle that if there is fluid, there is a major injury, and if there is, more importantly, the absence of fluid, there is no major injury. However, we know that there is some debate about whether or not this is true, and certainly looking at some of the studies in the past, out of 359 trauma patients, 313 had negative fast scans, and that's despite the presence of almost 40 significant solid organ traumas. So what does that mean? Well, ultrasound certainly has a role in the unstable patient, and we are talking about the major injuries. And that's the role of fast scanning, bear in mind. So we are talking about simply Doppler and B-mode imaging. However, in the stable patient where you're picking up single organ trauma, there is some debate. And of course, CT is prevalent and is widely prevalent. And because of its panoramic style of imaging in a very short time period, and also a relatively universal ability to read, along with clinicians as well as radiologists, it has become the gold standard for trauma imaging. That means that you allow a high sensitivity to internal injuries. And there are some groups that in the past said that ultrasound has certainly reached its limits in terms of the trauma setting, and that actually only 43% of abdominal solid organ traumas were able to be visualized with ultrasound when you compared it to CT. And these numbers are quite alarming, really. But that's not where the story ends. Contrast-enhanced ultrasound over the last 20 to 25 years or so has come into a forefront. And although it's recognized very widely amongst many clinical teams for its uses, the one that everyone seems to think about is the hepatic use and characterization of liver lesions. But EFSAM have obviously brought out their guidelines and recently updated the non-hepatic guidelines. And really, that is, rather than non-hepatic, it is the everything else guidelines. And that includes, in respect to trauma, hepatic injuries as well as every other organ injury. There is an acknowledgement that simply contrast-enhanced CT is hard to beat as an emergency modality. And again, we are talking about the polytrauma unstable patient. However, that makes up a small minority of the volume of total traumas that are present. Realistically, what you see more often is small volume trauma, possibly single organ trauma, and there is a need to exclude rather than a need to include an injury. And that's why the recommendations exist, which are that CT can be used as an alternative, contrast-enhanced ultrasound can be used as an alternative to CT in the stable trauma patient, particularly important in the pediatric patient, where there is a strong reluctance to expose to radiation, especially if there is a blunt trauma. You may need to do a biphasic CT, that is 2 exposures in one, not to mention the follow-up. There's also certainly the impression that CT is not the perfect modality of imaging. No modality is a perfect modality, but you can have uncertain findings, and you are looking at a single snapshot in time compared to a dynamic image. So you may get uncertain findings, and that's where contrast-enhanced ultrasound can help as well, particularly in things like perfusional abnormalities or incidental findings. Perhaps what we use it for the most in King's is in the follow-up of major trauma and single organ injuries, particularly splenic, hepatic, renal lacerations, where you want to see retraction of a scar, or you want to see that there is an improvement and no development of a pseudo aneurysm particularly. So does it help though? Does it actually make any difference? Well, in this study that looked in, and not long after those previous studies were released that criticised ultrasound, it looked at 210 hemodynamically stable trauma patients. And those that had a negative ultrasound underwent a CT and CUS. Actually, you can see that you've doubled your sensitivity from a 40% on baseline ultrasound to 80% on CUS. But the conclusion is perhaps somewhat paradoxical there, that what the authors have suggested is that it's insufficient as a modality, contrast enhanced ultrasound, that actually there's still 1/5 of traumas that are not being picked up, 1/5 of solid organ injuries that are not being picked up. So a larger study was released as a multi-center study, and this was quite interesting because it looked at the confidence of your diagnosis on baseline ultrasound, contrast enhanced ultrasound, and contrast enhanced CT, and it looked at the solid organs. And what you can see from those figures in that first table is a dramatic increase from a baseline ultrasound to a contrast enhanced ultrasound. And really, to be honest with you, there's very little in terms of difference between contrast enhanced ultrasound and contrast enhanced CT for the ability to make a certainly at least possible diagnosis, if not a fully definitive diagnosis. And in relatively rare cases was it that diagnosis was not possible. So with regard to bleeding in trauma, the sources of trauma is important, whether it's blunt trauma, penetrating trauma, or an iatrogenic trauma. And this then influences, in terms of CT, what type of imaging we can perform, whether it's a split bolus or an arterial venous phase or pre-phase, etc. And what we're looking for differs. We talk about active bleeding, we usually refer to active arterial bleeding. Venous bleeding, because of the low pressure, we're not really generally concerned about and usually seals itself off and often requires no further intervention unless it's a major vessel. Pseudoaneurysm is the next temporal step, which is where you can get some capping off and essentially a contained bleed outside of a vessel, but without leaking to the abdomen. The problem is those are prone to rupture at any moment. And hematoma is what results from the venous bleeding or the sealed arterial bleeding, and presents often as a laceration through parenchyma. Conventionally, we grade trauma according to the AAST, the American Association for Surgery and Trauma guidelines, and this has previously been quite heavily criticized because the predominant factor for grading a laceration is based on whether or not you have complete major arterial avulsion at the porta, for example, in the liver, whether or not you have a subcapsular hematoma, and what the length of it is. So the length of it varies from person to person because the organ length varies from person to person. Particularly, again, I refer back to pediatrics and the importance there. But also, there is no account for active bleeding with capsular rupture or without capsular rupture. That has changed now since in the 2018 revision, where you can see grade 3 now involves the presence of contained bleeding within the parenchyma, and this is just as an example for the liver, or grade 4 becomes bleeding external to the parenchyma. And actually, again, you're no longer talking about depth in the same way of a laceration. What about active bleeding? Well, a number of studies have been done which looked at contrast enhanced ultrasound in trauma because it is certainly lends itself well. The imaging of the abdomen is usually adequate with a 3 to 5 megahertz probe, which we know that the contrast resonates best at. And we know that you have a dynamic real-time modality. So you're no longer being given snapshots of what's going on. You can watch perfusional abnormalities, you can watch active bleeding, and you know that you have a truly intravascular agent, which means contrast seen outside of a vascular structure simply must be a bleed. And there are several studies that looked at this, and in our previous speaker's study, they noticed 18 cases of active bleeding. In another study which looked at a number of cases of emergent contrast enhanced ultrasound, not just for trauma, but also for potential things like angiosarcoma rupture, they were able to clearly identify active bleeding as well. And again, in a slightly larger study which compared to CT, they were able to notice there's no significant difference in the ability to pick up active bleeding. What active bleeding presented as was either a rounded hypoechoic area on B mode ultrasound, which was hyperechoic with pooling contrast, which rapidly increases in size, or if there was a high pressure bleed, a high volume bleed, there was a significant fountain-like or hyperechoic jet. And here's an example of an iatrogenic bleed following a attempted non-dilated PTC. What you can appreciate there is you can see that hypoechoic B mode pool with then the jet of contrast coming out, which is slowly pooling. Importantly, the bubbles are static within them, and that area is, even on this short clip, you can see it is rapidly increasing in size. And that was confirmed at CT and angiography where there are multiple bleed points. Moving on to the next temporal step, we have the pseudoaneurysms. These are different to the true aneurysms. A normal vascular wall is comprised of the intima, media, and adventitia. And we know that with a true aneurysm, you have involvement of all three walls. And to an extent, this may make it less likely to rupture, obviously dependent on size and location. With a false aneurysm, usually there's an insult to the vessel, whether that be infective insult, whether it be a direct trauma, or whether it be a shearing effect or deceleration injury. And you end up losing some of the structure of that wall, if not all of it. And often you have a bleed which is then essentially contained by a small clot around the outside. What that gives you is your typical appearance on B mode of a rounded or lobulated structure arising from a vessel, with a very typical yin-yang appearance on color Doppler, which is what we see in the image on the far side. These are then more likely to rupture because they have a very minimally contained wall. So we looked at this in our pediatric population at King's because we do a lot of pediatric trauma, and out of 101 cases that were admitted with liver and splenic injuries specifically, they were all followed up at 5 to 7 days, and as is conventional with us, we followed them up with contrast-enhanced ultrasound in the case of particularly single-organ trauma. And we found that there were 17 children that developed pseudoaneurysms. That's almost 20% developing pseudoaneurysms, of which 6 of those became symptomatic and required embolization. Now, this showed that the sensitivity of CEUS at detecting pseudoaneurysms was 83%. The specificity of 92%, and that's what I think is a more important number, is the 92% there, because you want to be able to safely discharge these children home. That is in contrast to what the American population have published previously, which is that pseudoaneurysms are reported to be less than 5%. So actually, contrast-enhanced imaging post liver and splenic injury, at least, is mandatory and requires follow-up for a prolonged period. Now, this was met with some animosity, perhaps, from American colleagues, suggesting that actually pseudoaneurysms are vanishingly rare, and that what we are seeing is not in fact a pseudoaneurysm, but is a contrast blush. Now, this is interesting because this is very much a reference to a CT image where you may get perfusion of abnormality, particularly with the advent of a split bolus protocol where you administer an arterial and a venous bolus at the same time. What you see when you see a pseudoaneurysm on contrast-enhanced ultrasound, it is definitive. There is a clear vascular connection and there is a clear circulation of the contrast within that area, and we can see very nicely an example of a splenic artery pseudoaneurysm here. There is also evidence to back up the need for a delayed phase imaging, and this is because this group here demonstrated that you do get delayed splenic vascular injury as well as delayed active extravasation from the spleen. And whilst there may be delayed active extravasation, the thought process is that this will arise from a pseudoaneurysm. So it is mandatory to follow up, and the same principle is true of the liver and indeed the kidneys as well. And we can see that these occurred slightly later, and they did occur 5 to 7 days, up to several days after injury. And I think particularly in the pediatric population, this is very important because this is the group in which we want to avoid repeating CT. We want to avoid the equivocal finding. And in the spleen, we have that zebra stripe appearance, which can make identification very difficult. Conversely, B mode and Doppler imaging we also know are not sufficient, because we can tell, for example, on this B mode imaging, whilst we can see there is some evidence of injury, a Doppler image does not really demonstrate the pseudoaneurysm, which is clearly lit up along the side of the vascular plane. And because it is usually adjacent to an avascular area, then actually you can see the pseudoaneurysm incredibly well. I'll talk very briefly on hematomas because they are very simple to explain in terms of contrast-enhanced ultrasound. They are a laceration plane that simply fills with hemorrhage, whether that be from venous injury, in some cases a biloma, or whether they are an arterial bleed that has then bled enough to tamponade itself with a relatively intact capsule. But the location is important because, again, that changes the AAST grading, and that determines whether or not further intervention is needed. Whether it's intraparenchymal, whether it is subcapsular, whether it's intracompartmental, such as peritoneal itself. And I'll show you some examples of some of these cases that I've mentioned. So this is a case of a splenic injury, which you can see very clearly the laceration, which you cannot really see on the plain grayscale imaging. Moving on, you can identify the very subtle lacerations and indeed the subcapsular hematoma, which are not, again, appreciable on either a CT or the B mode image. In terms of delayed splenic vascular injury, you can also get arterial avulsion, you can get a thrombus forming and dissection, which can result in largely devascularized splenic parenchyma. And again, this is important because that represents a bed of infection that can happen and splenectomy may be required. In terms of what we can identify as well, we can identify the very subtle lacerations, and you have operator dependence on this. So as long as you can see well with conventional ultrasound, contrast-enhanced ultrasound will boost your appearance. What you can say is, for example, this small handlebar injury of a 13-year-old, that laceration can be followed up. It does not need biphasic CT every time. And over the course of a couple of weeks, that's a few scans that you can be sparing that child. Indeed, in penetrating trauma, you can look for follow-up complications. This is a small biloma that persisted after several scans, and you can identify that. And again, you can check to see whether there is connection with the duct, whether there is drainage from it. We had another case which was after gunshots, and when you have multiple hyperechoic structures within the liver, you can actually identify again the tracks of the bullet, etc. This is another example of a subcapsular hematoma where you can appreciate the very subtle lacerations on the liver surface as to the reason why this is persisting. And again, the small contusions. And this is where I think contrast-enhanced ultrasound really holds its own and it reasons as to why it is in the EFSM guidelines. The small injuries, the child who has relatively little to find on examination, they may have perhaps a trace of blood in their urine, and actually you just need to rule out an injury. You just need to make sure there is nothing. The majority of patients will not show any trauma, any injury. However, there may be one or two that show a small subtle contusion that may require further imaging, because of course contrast-enhanced ultrasound cannot assess the collecting system as it is a purely intravascular agent. That said, the majority of these cases you will want to discharge as benign and no further follow-up needed. So that's where contrast-enhanced ultrasound, I think, is very useful in the pediatric low-impact traumas. Here's an example of another gunshot injury where you can identify the degree of devascularization of the kidney, which may be difficult to appreciate on single-phase imaging. Furthermore, we talked about delayed vascular injuries. So this is an example, unfortunately, of a 3-year-old child who had a dumbbell dropped on their abdomen at their father's gym. On CT, there looks very much like this arterial transection of the left renal artery. The grayscale appearances don't really reveal much other than a traumatized kidney. However, a couple days later, there's a presumed complete infarction of the kidney. the patient underwent a contrast enhanced ultrasound. Actually, what you can see is the kidney is supplied by medullary collaterals. What you have instead is a very exquisite example of cortical necrosis, which was echoed on the MRI. But actually, again, it doesn't require a general anesthetic. It doesn't require potentially harmful gadolinium contrast. And in terms of a follow-up CT, obviously radiation was not something we would desire. So that's why the patient had an MRI. Instead, a contrast ultrasound shows you entirely everything you need to see. And indeed, in the follow-up, even of quite complex lacerations, you can see the progression over time. And it's very easy to take the same images each time if you need to. And video loops and cine loops allow us to clearly delineate what was thought to be very operator dependent previously. Here's an example of that pseudo aneurysm again in the spleen. And again, you can clearly see the very vascularized component, which is definitive that you can see it's associated with an artery. You can see that it's arterial arterial echogenicity rather than a zebra stripe pattern of the spleen, and it persists into the venous phase. You can image it in any plane you want. You can be definitive that you do have a pseudoaneurysm. And indeed, in our population, what we also do is we follow up post-embolization of these pseudoaneurysms to ensure resolution. Now, this may be the case. It may be difficult to see, particularly if you fill a sac with coils and you're not sure the echogenic material there is from coils on Doppler, and you may cause artifacts on Doppler. On CT, you may simply see a lot of artifacts and not be able to assess the surrounding area. But contrast enhanced ultrasound means that you can definitively tell that you have treated this area. And indeed, you can do it at the same time as intervention, and you can also be able to tell whether or not you need further embolics at that moment. So in summary, contrast enhanced ultrasound represents an ideal modality to identify vascular injury, as it is a purely intravascular agent. The spatial resolution is only getting better with the advent of new equipment, and you have one of the few modalities that have dynamic real-time imaging without an invasive component. You do have to acknowledge, though, that you lack the panoramic ability. So the global imaging, CT still remains the gold standard for the polytrauma patient. However, in a situation such as on a battlefield, it may well be that contrast enhanced ultrasound shows its utility when you have a defined entry and exit point, such as a left upper quadrant stab wound. You want to identify splenic trauma, where CT is simply unavailable. And I think the biggest utility is in this follow-up of solid organ injury, where we can spare patients unnecessary CT of what is already a very oversubscribed modality. And in cases where we have to acknowledge that CT is not perfect, we will see focal fatty sparing, we will see incidental findings, we will see perfusional abnormalities. And a contrast enhanced ultrasound can simply be performed either at the time of CT or at the bedside immediately after for the patient, and rule these out as potential injuries. So I'd like to echo the ESTM guidelines that contrast enhanced ultrasound can be used as an alternative to CT, and I would advise it in the likely single organ injuries where there is moderate to low energy trauma, particularly in children, and to evaluate the uncertain findings, and particularly, most importantly, for the follow-up and identification of pseudoaneurysms and to ensure resolution. Thank you for listening.
Thanks, Tim, for your great presentation, as always clear and comprehensive, and the good quality of images that you showed. There is a question for you. Matthias Johnson is asking, what is the dosage of contrast agent you use during this kind of examination?
So it does vary, because depending on whether we're dealing with an adult or pediatric population, our pediatric population, we tend to half the dose for below 12 years and quarter for 6 years. So using either 0.6 or 1.2, depending on the organ examined. There are some studies that have shown that you inject 1.2 for each side, and you look at the right kidney and liver in one go, and then you do splenic and left kidney in the other side. It does help to have 2 injections, because you can identify the arterial phase that bit better, particularly if you need to spend slightly longer. Or obviously in a trauma patient, there may be a lot of overlying bandages and equipment, etc. That is also a utility, however, for the flash tool. Being able to, as we see in liver lesions, being able to revisualize the arterial phase and see the presence of a pseudoaneurysm to find where it's coming from. So I would not, with new equipment developing further, I have found myself reducing doses as well. I have found myself using 1.2 as a standard in adult livers.
Totally agree, and also taking care of the possibility to use for other vascular application, such as the carotid stenosis and the endovascular repair evaluation. We usually suggest 1.2 milliliter, and sometimes even less. It depends
Absolutely.
on cardiac output, patient weight, general indication, and of course, the quality and the sensitivity of your equipment. And remember, when you use too much contrast, especially for vascular, you can have the blurring artifact and you can miss some important information, especially in order to depict the very tiny active bleeding or the neovascularization of the plaque or the small tiny emboli. So in general, to try to answer to Matthias Johnson, dose is relative to the patient, is relative to the indication, is relative to the equipment that you are using. I hope that you agree with me.
Absolutely, completely.
So we ended this very interesting, very promising webinar because as we showed, COS has established a role in many fields. For sure, in the vascular application, it is already recommended as important first or second line imaging modality. Depends on the indication, depends on the clinical scenario, and it depends on your experience. So far, I announce you that in the next Eurozone that will be held in Bergen, Norway, we will provide interesting course to try to make you even more be experienced by using of COS. I wish you a great day. Efsun wish you a great day. I hope to see you soon somewhere in the world. Arrivederci. Bye bye. And remember, the Efsun will host this webinar in our website. As you can see here, you can find also the link to the quiz, and you will receive the link to the quiz by mail. Again, have a good day, and I hope you enjoyed this very interesting webinar.